Hello, my name is Justin Beard, and today I'm going to be presenting to you my capstone project. For my topic, I will be discussing ventilator-associated pneumonia in the intensive care unit. So let's go over the objectives we're going to be covering. We want to raise awareness of VAP in ICUs internationally, discuss the prevention as well as promising studies for future interventions, as well as review the current best practices for prevention of VAP in mechanically ventilated patients in the ICU. So what is VAP? VAP refers to the development of the parenchymal lung infection after undergoing intubation and receiving mechanical ventilation for greater than or equal to 48 hours. So we have two types of VAP, early onset VAP, which occurs within the first 4 days of hospitalization. And then we have late onset VAP, which occurs 5 days or more after hospitalization. So those are the two types that VAP can be grouped into. And as this project focuses on VAP prevention, I will more specifically be referring to early onset VAP, but I just want to let you know that I may synonymously be saying VAP and EOVAP together, as to prevent any confusion on the topic of VAP. So as far as the prevalence of VAP, it's the second most common nosocomial infection in the intensive care unit. Estimated 9 to 27% of VAP occurs in mechanically ventilated patients. Looking at patients that are in the ICU, 39.5% are receiving mechanical ventilation at any given hour. And we also have various studies that have looked at the estimated cost of treating VAP, and the reports have ranged from $10,000 to $40,000 per patient. That's extremely large. So prevention of VAP is key because that's a very costly thing to treat. We're going to look at some of the risk factors now. Some of the risk factors for VAP include extended length of hospital stay and time on mechanical ventilation, previous history of hospitalization with antibiotic treatment, reintubation, COPD, CVD, diabetes, organ failure, male sex, and being admitted as a trauma patient. So before we discuss research for future best practices, I just want to briefly touch up on the IHI's original VAP bundle and for VAP prevention. And many facilities do have some sort of VAP prevention bundle that they utilize. It may not exactly be the IHI's VAP bundle, but I would say the vast majority of facilities do have some sort of VAP bundle in place to prevent development of VAP. So looking at the IHI, they're the Institute for Healthcare Improvement, and in 2001 they developed the VAP bundle, and it traditionally has 4 elements. One is head of bed elevation between 30 to 45 degrees, sedation holds, which is to try and wean the patient off mechanical ventilation, peptic ulcer disease prophylaxis, as well as DVT, deep vein venous thrombosis prophylaxis, as long as it's unless it's contraindicated, which would probably be for like your bleeding patients, things of that nature. So from 2004 to 2007, the original IHI ventilator bundle led to an 89.7% reduction in VAP in mechanically ventilated patients, one study has shown. So, other preventive measures. Can prophylactic use of antibiotics prevent VAP in mechanically ventilated patients in the ICU? So, many patients in the ICU are receiving antibiotics at some point in time. What's very common on a medical ICU or medical surgical ICU, it would be admission for sepsis, urinary tract infection, or prophylactic use of antibiotics, pre and post-surgical intervention. And so that kind of led me to this question. Whether prophylactic antibiotic use could reduce the prevalence of VAP in mechanically ventilated patients in the intensive care unit. So with that question in mind, I formed it into a Peacock question. And that question is, in patients that are mechanically ventilated and currently receiving a VAP bundle, will administration of prophylactic antibiotics in conjunction with a VAP bundle compared to only receiving just the VAP bundle, lead to reduced occurrences of early onset VAP over the course of 1,000 ventilator days. I know that's kind of a mouthful. Looking at that, not much research, but what was found, Rai as well as colleagues in 2017, their findings showed decreased development of early onset VAP and shorter ICU length of stay in patients that received the VAP bundle and prophylactic antibiotic administration. With regards to development of multi-drug resistant pathogens in VAP prophylaxis, studies have shown short-term antibiotic use to lead to less frequent multi-drug resistant pathogen development as opposed to longer courses of antibiotic administration. Because with here, we were looking at prophylactic antibiotic use as a preventative measure in development of VAP. However, there is that concern of developing like antibiotic resistance and multi-drug resistance pathogens developing. So there is some research showing that shorter courses have shown less likelihood of that developing as opposed to long courses of antibiotics. But we do need more research on the subject. So looking at this, these findings are significant and that they may be used to develop a future treatment plan or protocol in VAP prevention, but we are going to need more research and these studies will need to be replicated. But with the concern for potential multi-drug resistance in antibiotic administration, we will need further research with that to analyze ways to reduce such likelihood, as the costs may outweigh the benefits. So now we discussed the IHI's initial 4 elements of the VAP bundle, so now we're going to look at it with the addition of the 5th element. We do have the elevation of the head of the bed between 30 and 45 degrees, the daily sedative interruptions, and daily assessment of readiness to extubate, which some facilities would call sedation vacations. We have the PUD prophylaxis, DVT prophylaxis, and then in 2012, we have the addition of the chlorhexidine, daily oral care of chlorhexidine. So now we're going to take a quick look at a VAP bundle in action.
包含下列5个措施 ：A. Assessment of readiness to extubate each day， 每日评估是否拔除气管内管。B. Bed head up 30 to 45 degrees， 床头抬高30到45度。C. Chlorhexidine for daily mouth care， 每日使用2% chlorhexidine 消毒剂进行口腔照护。D. Discontinue sedation each day， 每日终止镇静剂。E. Evacuate ventilator circuit， 排空呼吸器管路积水。
So this was a VAP bundle that was used at a hospital in China, and this just goes to show that the practice is used internationally, using a VAP bundle to prevent VAP in mechanically ventilated patients in the ICU. So although the VAP bundle didn't consist of a PUD or DVT prophylaxis, it did consist of the 3 elements of the IHI's VAP bundle that specifically targeted prevention of VAP. The addition of evacuating the ventilator circuit, I did find that interesting, and it seemed like a good additional intervention as moisture in the patient's oral secretions harbor bacteria, and that can contribute to VAP development. But on the ventilators that we use at my facility, they do have what are called heat and moisture exchange filters. They're these little filters that connect onto the circuit, and they help retain moisture in the respiratory tract while collecting the patient's secretions. So that's something good to help prevent that. So now we're going to look at a couple of significant findings. Cutler and Sluman found that oral care with 1% oral chlorhexidine reduced VAP by 50%. In one study where the VAP bundle showed 70% overall compliance, Morse and colleagues found rates of methicillin-resistant Staphylococcus aureus, MRSA, to drop from 10% to 3.6%, and that's with 70% compliance of the treatment plan. So those numbers could be even better. A randomized control trial showed 18% fewer cases of VAP in patients lying in semi-recumbent, 45 degrees position, as opposed to the other group that was laying in supine position. So those are some significant findings of the IHI's VAP bundle. So why VAP? VAP bundle implementation may provide the following benefits, some or if not all: reduce incidence of VAP, more rapid ventilator weaning, shorter length of ICU stay, shorter length of hospitalization, and reduce burden of healthcare costs and ICU resources. So not all studies, in my findings, not all studies that I've researched on the VAP bundle did show all of the following benefits. However, a majority of the studies that I did review had a combination of either some of these benefits, if not all of the following benefits. If your facility doesn't utilize VAP bundle, I would discuss that with your ICU director or your educator, unit educator, or whatever you may have. So you can also look at the articles at the end of this presentation. If you want to go through the sources, you can look at those as a means for extra information regarding VAP prevention. So in conclusion, VAP is the second most common nosocomial infection in ICU patients. VAP treatment costs can range from $10,000 to $40,000 per patient, and short-term prophylactic antibiotic treatment of VAP may be utilized in the future once we have more research to see how beneficial it may be. And also, VAP bundle has been shown to reduce incidences of VAP along with various other benefits. Alright, so now, if you wouldn't mind, I'd like you to, in the actual PowerPoint you have that came with the video presentation, I'd like you to just go ahead and check out this website link right here and take a short 7-question quiz just by clicking the hyperlink. I hope you learned something new and will practice prevention of VAP in your workplace if you take care of mechanically ventilated patients. I really hope you all learned something. Thank you. Here are my references.